Good afternoon, everyone. We're going to get started here. Welcome to the Healthy Transitions Colorado September 2014 webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm really happy to be here with you today as we review and discuss updates on the medical orders for scope of treatment. Let's see here. So Civic is the managing partner for Healthy Transitions Colorado in collaboration with our partners Telegen, formerly CFMC, the Colorado Hospital Association, the Colorado Healthcare Association, and Colorado Rural Health Center. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating the existing efforts to improve transitions of care for Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. We coordinate the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for this campaign follow the triple aim. Over the 2 years, we hope to eliminate 8,700 readmissions, or 20% reduction in the statewide readmission rate, eliminate over 34,000 days in the hospital, and save over $80 million for Coloradans. If you haven't already done so, we'd like to invite you to become one of our community partners and take a pledge to improve patient care transitions. To take the pledge and learn more about HTC, please visit our website at www.healthytransitionscolorado.org. So just a couple of housekeeping things before we get started today. The phone lines have all been muted, and they're going to remain so throughout the webinar. We'll use the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Any questions you make to the presenters will be answered during the Q&A session at the end of the presentation. This webinar is being recorded and will be posted to the HTC site, so you can access this information again at any time without cost. So I'm now going to turn the program over to Dr. David Coates, the Chief Medical Officer of the Denver Hospice, and Jennifer Ballantyne, Vice President of Hospice Analytics. Dr. Coates and Ms. Ballantyne are co-chairs of the Colorado Advanced Directives Consortium, which launched the MOST program in Colorado in 2010. Jennifer? Oh, David, start.
Great, thank you, and my thanks to all of you for taking time out of your day today to join the webinar. I think that as we get into the objectives of the meeting today, one of the things that's really important is the tools and the processes that we are using to have conversations with patients, specifically around end-of-life care. And as we look at transitions in care in general, this is a really very crucial part of defining the care that we're providing for patients based on their values and goals. So our objectives for today are really to look at the now refined definition of palliative care that is listed in the Chapter 2 regs. I'm going to give a little bit of an overview on where things are with POLST and the POLST paradigm nationally, and talk a little bit about how Colorado is connected to that. And then spend a little bit of time talking about what goes into having the conversation. I think that since we have rolled this out over the last 4 years, that it is very easy to have a focus on just the form. And I think that where we need to really move and kind of shift our focus a little bit is into the processes and the conversation and the components of the conversation that go into completion of the form and documentation of the patient wishes. We are in the midst of making some changes in the form since it has been out in use for approximately 4 years now, and I will be going over briefly the updates on those, and then have time after that for questions or input from all of you based on your experiences over the last few years. So with that, I'm going to turn it over to Jennifer and talk a little bit about the palliative care definition and the content that's in the Chapter 2 regs.
So this may be news to some of you. There is now an official definition of palliative care and some standards that have been added to the Chapter 2 regulations for healthcare facilities. As of March of last year, when the Board of Health officially adopted the definition and standards, This was the culmination of a several-year-long process that was spearheaded by the Colorado Center for Hospice and Palliative Care with the very close cooperation of Civic and the Life Quality Institute to really try to come up with a definition of palliative care that would be coherent with the various national definitions that are out there, but also applicable in any healthcare setting across the state, not specific to hospitals or hospice or nursing facilities. So the definition is here on the screen. We will be posting handouts to the web page, the Civic web page after the webinar, and the definition and the standards will both be in one of the handouts, so don't feel like you have to scramble through and copy this down. I just mainly wanted to point out to you that the definition does exist and it is in the regulations. In addition to the definition, there are several standards so that any healthcare facility that is claiming to offer palliative care must have documentation, must have policies and procedures and documentation regarding how, for each patient who is receiving that palliative care, how they are going to be provided with the following services. And one of the things I want to point out here is that this is not a situation of one or the other. This is all of these various services. So it includes assessment and management of patients' pain, goals of care, provision of or access to services for psychosocial and spiritual needs, access to a support system to help the family cope, and as indicated, referral to bereavement support or resources. So if we go to the next slide, this is what I just really want to highlight, because goals of care and advanced care planning is a really key feature not only of these standards, but obviously of palliative care generally. And the medical orders for scope of treatment is one of several tools in the toolkit in Colorado for advanced care planning. But as you'll learn or already know, the most is especially critical in managing transitions. So with that, I'll turn it back to David, and he'll give you a little bit of an overview of the most generally and an update from the national perspective.
So I'm going to make a couple of assumptions here. One is that most people are familiar with medical orders for scope of treatment, or most. But just to really put that into perspective of where things are at from the national standpoint and with the national POLST paradigm, is that MOST is an acronym that is just one of many that is being used across the country. Various states have variations on the POLST paradigm acronym, or physician orders for life-sustaining treatment, to include medical orders for life-sustaining treatment, physician orders for scope of treatment. And there was a lot of discussion in Colorado when we were putting this together and starting on this process about 7 years ago now, of where we landed with medical orders for scope of treatment. But just to understand that this is a part of the larger paradigm that is has guidelines and expectations that are defined by the National POLST Paradigm Task Force. So when we go to the next slide and look at where things were and what the components of the medical orders for scope of treatment were really intended for, is we really identify patients that are at those specific transition points. Medical orders for scope of treatment is not an advance directive, number one. This is medical orders to define the care that an individual wants that is specifically related to where they are relative to their serious illness. It is not for every patient. But as patients are dealing with chronic disease processes, and those chronic disease processes ultimately will end up at a point where they are terminal, those are the kinds of triggers to then begin to have the conversations and more definitive and directive conversations around advanced care planning and defining the care options relative to that patient's goals. The MOST form in and of itself does help to guide that conversation. Again, that's the most important piece of it. And unlike the living will or some of the other advanced directives that are out there, its intent is really to address the current condition of the patient. What has changed relative to their disease process? And as a result of that disease progression, their goals, their values, the influence of their values very well change along the way. And we need to have a mechanism to, number one, to document what those care wishes are, and number two, to update those as conditions progress. It does allow clear choices as opposed to the ambiguity that sometimes lives within living wills. Living wills are fine and good, but very rarely are they applicable at the bedside when we're making decisions about the appropriate care or the appropriate interventions for an individual that is in a healthcare setting. I think one of the other challenges that we've had in looking at how we're providing care across the continuum in healthcare is how do we then convey and communicate the information that is the result of these conversations to other healthcare providers that may be participating in the care of the patient. The most form in and of itself belongs to the patient. It does not belong to the chart. And it's something that the form is really intended to be applicable across settings. And then with those key trigger events in the course of the disease process, then to be updated accordingly. It is relative in a hospital setting, it's relative in a subacute or a long-term care setting, assisted livings, or in hospice or palliative care programs. I think one of the things that's really important to remember as well in having conversations around advanced directives or medical orders for scope of treatment is that this is a process and not an event. That once it's done, things do change, and that we need to have a process that is built into the guidelines around most to have it regularly updated and to review the conversations, review the patient's wishes, review what their goals are, as I alluded to earlier, as disease processes progress. And then just to reiterate that the original stays with the patient, copies, faxes, scans are all valid documents in the settings where those types of the form are available. When we look nationally at where we have been, and this is a map of the activity around the POLST paradigm from 2008. Colorado became a developing state, which is shown on the slide in light pink, approximately a year prior to this. And there was a fair amount of activity across the United States. The POLST paradigm itself starting in Oregon, then moving actually fairly quickly into Washington and then a couple of states on the East Coast. But it's been amazing to me as we then look at the progression over the last few years as to what is happening nationally as far as progress of the POLST paradigm in various states. And to where we are today in 2014, you can see there's been tremendous activity in the last 6 years, and especially in the last 1 to 2 years, in different states becoming developing programs, Colorado becoming an endorsed state, which are the states that are in the dark pink. And as of yesterday, Oklahoma was the last state that was added to the map, becoming a developing state, leaving only 4 states where there is minimal activity at this point in time. I do have to say in my involvement and work on the National POLST Paradigm Task Force in the Developing States Advisory Committee that those 4 white states do have definite interest and are in the process of putting together the initial components to be able to move forward and becoming a developing state. My guess is that within the next 12 months that we will see the entire United States be some shade of pink. We now have enough activity relative to the outcomes, which I think is something that's really important to look at, and enough participation that we now have data that is really reflecting what is the outcome of the POLST paradigm, and is it meeting the expectations of what we expected. If we're having the appropriate conversations, documenting the patient's wishes relative to the treatment options that they want based on their goals, what is that looking like? This is a study that was published this year in the Journal of the American Geriatric Society by our colleagues primarily out of Oregon. And when we look at the next slide and the number of charts that they reviewed, there was a very large number of patients that they looked at through their Pulse registry. The key pieces that I want to point out on this slide is not so much the number or the percentage of individuals who picked the level of interventions that they wanted, whether that be comfort care, limited interventions, or full treatment. I think the key piece in those three numbers is the fact that these are conversations that are happening with patients with serious illnesses. And that as we define their care relative to their serious and progressive illness, that almost 2/3 of the patients wanted comfort measures. And then you can see the distribution as far as limited interventions and full treatment. The next step in looking at the data relative to the outcome that is really important is that then where did those patients die who chose those particular levels of care? And of those patients, those 2/3 of this particular group that was looked at that chose comfort measures only 6% died in the hospital. That means that these patients were receiving the care that they defined that was appropriate for them, that a hospitalization oftentimes is not appropriate given the level of care that they want, and they're ultimately dying where they wanted to die. I think on the other end of the spectrum, that those patients that wanted full treatment, a little less than half of those patients died in the hospital. There's many variables that go in, and you can access the article to look at the specifics of what were the characteristics of that particular group of patients. But you have to always remember that many chronic conditions have sudden death as a part of their death, and they're not going to make it to the hospital. But the key is that their care was defined, and those that wanted care that were able to get to the hospital received it there. And that compared to then about 1/3 of patients that were looked at in this group that had no pulse form. About 1/3 of those patients died in the hospital, and that's about what we're seeing nationally as far as where deaths are occurring when we look at that globally, disconnected from disease processes or conversations around advanced care planning. So I think this data is really very, very important in looking at what are the outcomes that we are experiencing relative to having the conversation around end-of-life care, and then having the appropriate documentation that is giving direction to healthcare providers regardless of where the patient is landing. I'm going to turn it back over to Jennifer to now talk a little bit more about some of the specifics of the conversation. I think this is the piece, again, that as we have implemented the MOST form, there's been a lot of focus on the form itself. And I think this is the time that we really need to have a little bit of redirection in looking at what is the process that goes into the choices that are chosen and then documented on the form. Jennifer.
So again, just to remind everybody, we keep saying this and you'll get tired of hearing it, but advanced care planning is a process. It involves several different steps that have to be repeated, over time as physical conditions change, as attitudes change, as circumstances change. And it always involves discerning goals, planning care to meet those goals, following the specific instructions, which then are, this is where the documents come into play, and then also using them to steer all the parties in the same direction. We often say in these conversations that if you've had a really good discussion among family members or between patients and providers, oftentimes the documents are almost not even needed, and yet it's always helpful to have the documents in hand, particularly for transitions when patients can't necessarily speak for themselves, just to get everyone on the same page in a big hurry. But to emphasize that documents are only one part of the process and are the outcome of the conversation, not the the purpose of the conversation. So again, in your handouts, you'll find a pretty detailed two-page sheet that really goes into the steps of the most conversation in more detail. Also gives you some sample language for how you might approach the different steps with particular patients or residents in facilities. So I'm just going to kind of do this from a very high level and then refer you to the handouts for more detail. But the very first step here, obviously, is to determine the capacity of the resident/patient to participate in this conversation. Because the MOST form is really specifically designed for people who are already seriously, chronically, or perhaps even terminally ill, capacity is a question mark. And I'm not going to in any way suggest how you might go about doing that. Presumably you will have processes or standards for doing that within your setting, but it is an important step. And then if the resident or patient is not capable of participating or of making reliable decisions, to be sure to include the medical power of attorney or family members, anyone else who is in a role that would be making those decisions. It's always helpful at the beginning of this conversation to describe the purpose of advanced care planning and to normalize the process as much as possible. This can be a little bit scary, this conversation, particularly if it's the first time that the patient or resident has ever had it. So, if you all of a sudden, walk into the room and say, so, have you thought about a living will, or so, have you thought about, life-sustaining treatment? It can be a little alarming, but if you present it as a normal process, we do this with all of our residents. I do this with all of my patients. We want to be sure that we understand what you want from us in terms of your care. To just kind of put it in the context of, this is just part of what we regularly do, and it's important for us to know what you want. It's also very helpful to ask about any previously completed documents. As David pointed out, the MOST is not an advance directive. It does not replace or revoke previously completed documents, but we can get ourselves in a twist if we have contradictory instructions between perhaps long ago completed documents, living wills that have been sitting around for 30 years, or medical powers of attorney that are not very specific. So it's always helpful to ask about previously completed documents if they have any, and to take the opportunity to update them in the process of this MOST conversation. It's also especially important to identify the medical power of attorney if there is one. The MOST cannot be used to appoint a medical power of attorney, but it will be important to identify that person on the MOST. If the resident is not, has not appointed, or patient has not appointed a medical power of attorney, it's very important to initiate that process immediately if they still have capacity to make that decision, and if they don't, to make sure that you have the pieces in place to pursue a proxy process to identify an alternative decision maker. And you'll need to do that before you complete the form if the patient or resident has already lost capacity. If that medical power of attorney agent is present, it's also helpful to confirm their understanding of their role. What does it mean to be a medical power of attorney, and what does that entail and what does it not entail? And then throughout this process, clarifying any misunderstandings that seem to be expressed and correcting those as needed. So going on from this.
And actually, Jennifer,
yeah,
before you go on to the
sure.
next one, and I was just looking at the question from Joyce, and I think that...
They can't see these.
Okay.
So there's a question from Joyce Steddings asking if the medical durable power of attorney is required for a patient if they have a MOST form.
And with Jennifer's conversation around the medical durable power of attorney, that question caught my eye, and I think this is an appropriate place to address that in again, differentiating between medical orders and advanced directives. Medical durable power of attorney is an advanced directive, and as we look at the number of advanced directives that are available, the living will, I've already referred to, the Colorado CPR directive, 5 wishes, medical durable power of attorney, When we look at all those collectively as tools around advanced care planning and defining advanced directives, I will have to say that the medical durable power of attorney is the absolute most important advanced directive to have in place. And if that's the only one that is in place, I think that's really important. The medical durable power of attorney is not required for a patient to have a MOST form. A patient can fill out the MOST form, but it is a very, very important component to have that patient identify who they want to be their decision maker in the event that they are not able to make decisions for themselves. And while the patient still has capacity, that is absolutely the time to do that. And as Jennifer had alluded to, is what that sense of urgency is in identifying that individual, so we then don't have to go into a more cumbersome process of determining the proxy. If we've got time at the end, we can talk a little bit more about that if people want to. But I think that it's something that a medical durable power of attorney is absolutely essential. If the patient has lost capacity at the time that we are completing this, having that person already in place to help facilitate making the decisions that will ultimately be documented on the MOST form is absolutely critical at that point in time. And that's how the two of those really fit together.
Thanks, David, for that. And the other piece to that is, we recommend, if possible, even if the patient has full capacity, to have the medical power of attorney person there for this conversation and other family members as well, because the more everybody hears from each other about these issues, the better. Particularly for the MOST, only particular choices and selections are going to be documented. There is, the MOST is not a narrative document. So if someone only has the form to refer to later, that's very important, but it doesn't really give you the context. So looking further now as we go along in this process, those of you who are familiar with the palliative care consultation paradigm will recognize this recommendation that you start with exploring the patient or resident's understanding of their medical condition, prognosis, and the likely course of the illness and the treatment. And again, the handout will give you specific language for how to do this, but the important thing is here to get the patient or the medical power of attorney to really articulate what they do understand. So often, people don't really understand exactly what it is that's going on with them. They have questions. Things have happened very quickly. Things have been said in a language, or in terminology that they don't entirely understand. So it's very helpful to get them to articulate it. And then if there are very clear misunderstandings, to do what you can to clarify or correct that within your ability to do so, within your sophistication as a clinician or within your scope of practice. If there are questions that come up that you don't know the answers to, you can note those down for the physician later. And then likewise exploring their understanding of potential complications. What might be ahead for them given their particular condition? Is there some likelihood they might end up on a ventilator? Is there some likelihood that they might experience a sudden death? Is cognitive decline probable? To really explore some of those and make sure that they have a clear and correct understanding of what is ahead. Another recommendation is to explore and refer back to their own experiences of the course of their illness or other people's experiences. Now again, with the MOST, we're likely dealing with someone who is already seriously ill, who has a history with their own illness, and perhaps is fresh out of the hospital or fresh into the hospital and will be able to, explain what's been going on. And this helps them to tell their story, to put some shape around it, as well for you to understand how they are interpreting their experience. Are there particular lessons that they are extracting from the experience? And then finally, exploring living well is really a fun part of the conversation. Actually, sort of turns it to more positive things, to find out from the person what they enjoy, what gives their life purpose and meaning, what needs they might have, where they derive support, and then also to touch on fears and worries. Now you'll notice that we've gone through 3 slides on the most conversation, and we're only now introducing the form. And this really, this paradigm, if you will, for the conversation could be applied to any advanced directive or advanced care planning conversation. But all of this background will really help you and will expedite actually the completion of the form. But at this point, it's important to introduce the form, to explain what it is and why we're using it. And then as you go through each section, this is a recommended general pattern for each section. To explore the person's understanding of the option, for instance, if it's CPR, what do they know about CPR? What do they understand of the risks and the burdens and the potential benefits of CPR? And while we're talking about CPR, I'm sure all of you will, if I could see you, you'd be nodding your heads at this, that most people don't really have a good understanding of either what CPR is, what the risks are likely to be, how very infrequently it's actually successful, particularly in a population that is already elderly, frail, or ill. And people have perhaps not realistic goals or expectations around CPR. And it's helpful in this conversation for that section in particular to really explore what they do understand. And in your handouts, you will find a fact sheet that will that you can use for patient and family education around CPR that really does explain in fairly straightforward language what the likelihood of it actually working is. But for each of the sections, to explore their understanding, explore their goals and expectations and their fears or concerns, and then derive from that their likely choice for the sections. I do want to point out here that if after all this conversation the patient still says, yes, I do want CPR, the only possible option in the next box, in box B, is full treatment. You can't say, yes, I want CPR and comfort measures only. It just doesn't work. Yeah. On the other hand, if they pick no CPR, other options are possible. It's possible to have full treatment up to but not including CPR. So again, that's something to explain as you are completing the form. And just one last sort of tip on the conversation piece here. You might consider starting with box B, and if you're familiar with the form, you'll understand that that's the box that really defines scope of treatment. So if you start by saying, in general, do you want comfort measures only, full treatment, limited interventions, that may help you to answer the CPR question without starting there. And again, that can be kind of a scary or difficult topic to discuss. So finally, just a reminder to complete the action when you have had this conversation, to make sure that you obtain the signatures. If you are not authorized, if you having the conversation are not authorized to sign this form, to make sure that the signer, physician, advanced practice nurse, physician assistant on the provider side, the resident/patient themselves and or their agent, make sure you get the appropriate signatures, and particularly for the providers, make sure that they review the form before they sign off on it. If they have not had the conversation, they need to review the form, make sure it makes sense to them, make sure that they're aware of what the choices are, because once they sign that, they own those orders, and it's going to be important for them to be comfortable with what the choices are. Just again, a couple of quick reminders. Telephone orders are okay. Faxes are okay. There is no reason that a MOSE form should be sitting around waiting for a signature. It could be faxed to a provider to sign. An RN can get a telephone order and document that appropriately. File and follow up per your facility policy. Remember that the original belongs to the patient. And it's important to keep reviewing this. If you're in a nursing facility setting, quarterly care conferences are the appropriate time to review. if you're in the primary care setting, at any wellness visit or any change in condition, at any discharge or admission, readmission, for the patient who comes into your setting with the most or is leaving and perhaps being discharged to another setting to introduce the most or update it before they leave. And then just one final note, it is now possible in Colorado to bill Medicaid for a most conversation with a Medicaid beneficiary, and your handouts will have more detail on that. So just a few quick reminders. Like the CPR directive, copies, faxes, and scans are all valid. This is primarily a tool for communication through transfers and a guide to long life-sustaining treatment. The most cannot be required by any facility or provider. That's very explicit in the law, that you cannot condition treatment or care on someone's completing a most. It should be offered to all appropriate patients, but it cannot be required. Whoever completes the most, though, the most is valid in all settings. And its orders should be followed. There are really only two reasons to not comply with orders that are presented to you, on a most form. And one is if you deem in your professional judgment that the orders are medically inappropriate for the patient in the condition that they are in when you first encounter them. Or if you, as an individual or your facility or your agency, has an ethical objection to some of the choices that might be selected on the most, then it is possible to take a deep breath, go back to the patient if that's possible, or their decision maker and get and discuss a change and make a change. So with that, I'll turn it back to David, and he'll bring you up to speed on what we're proposing to update on the form.
So the current form that we've been using has been out there for just about 4 years now, and at the outset we had anticipated that we would come back and revisit the form and make some changes. This is something that essentially all of the states that are endorsed have been doing on a regular basis. I think that Oregon is now, who started this back in the early 90s, is now on their 16th form. We definitely want to minimize that. I hope to never reach 16, and that we have a lot of lessons learned from other states' experiences. But there's always going to be some variability state to state, because individual state statutes, individual state regulatory guidelines do vary and do have an impact on some of the language and some of the content of the POLST or POLST-like forms. So what I'd like to do is to just walk through with you some of the changes that we are hoping to have implemented in a final version of the revised form that will be available probably right after the first of the year. And the current form is available on our website, Colorado Advanced Directives. That will be on the references that you will receive in your handouts. And I'll point out a couple of others on the reference slide when we get to the end of the presentation. But to start with the form, the upper part of the form is just some general information and some general guidelines. We did change the language a little bit around that, and talking a little bit about if there are specific sections that are not completed, that the implication is full treatment. If we move down next to the next slide and looking at the specific boxes or the specific categories of the conversation, the first box is around cardiopulmonary resuscitation. The most significant change is that we changed the order for multiple reasons so that full resuscitation is the first choice and do not resuscitate or no CPR is the second choice. I think that this, and just to kind of point out a little bit of some of the nuances and some of the value added of this particular form with this section relative to the Colorado CPR Directive. When somebody is handed a Colorado CPR Directive to sign, if they don't sign it, the default is full CPR. And I think it's really important as we're having the conversation with patients around cardiopulmonary resuscitation and as Jennifer had alluded to talk about what are the appropriate expectations and the implications of full resuscitation. What are the appropriate expectations and implications of do not resuscitate? And I think that that's something that is really important, and the value added of having the conversation around the MOST form is being able to have that conversation about each one of those options. When we move to box B, and I just want to underscore what Jennifer had said, this is where I always start the conversation with patients, is we're getting that information to learn about the patient, identifying what their values are, beginning to have a conversation around what the appropriate goals are for that patient. That leads very naturally into what level of care that they want. Whether they want full treatment, full cord press, everything in the hospital, limited interventions, and what does that limited interventions mean relative to their disease processes, or comfort measures often that are in place when somebody is reaching the end stages of their disease process. Again, we change the order in this particular box where full treatment is the first option, and then can walk through what the gradations of that are and what are the implications as far as treatment options within each one of those categories. The next slide, in looking at box C, which is on the old form, is going to disappear from the new form. This was the discussion around antibiotics, and what we have found in looking at the data nationally is that everybody chose that antibiotics if comfort was the goal. So it really didn't add anything to really defining what was appropriate treatment. I think the other thing that this did, and the important piece of the conversation when we're talking about medications, is what medications are appropriate to continue when somebody is comfort measures in the end stages of their disease. And that is a conversation that we really need to be having, addressing the ongoing problem of polypharmacy. We see that in the geriatric population all the time. And I think having a more global conversation around appropriateness of medications and not just limited to antibiotics are a very crucial part of the conversations around defining treatment options. In moving to the last box around artificial nutrition and hydration, it was addressed on the old form. This is one that we really did a major...
I'm sorry, give it a moment.
we did a major overhaul on this particular box, and I think the most notable piece is to take out hydration from this box. So instead of a conversation around artificially administered nutrition and hydration, this really is a discussion around artificial nutrition. And the key pieces of the two real decisions is that, number one, is it going to be done? Number two, for how long? Or is it going to be done long term? And this is a very specific, definitive conversation that has far-reaching implications, and the specific disease and comorbidities that a patient has is a definite driver into the appropriateness of these interventions. And to be able to have that conversation specifically with nutrition is really important. The conversation around hydration is really a very different and separate conversation than the nutrition conversation. And even in the hospice world, we get requests for parenteral hydration or IV fluids in our patients for various and sundry reasons. And the conversation around that is very different than the conversation around feeding tubes and artificial nutrition. The very bottom of the first page, we did make some changes in this as well. On the old form, the last section or the last few sections were included who are you having the conversation with, and that piece I think is still really, really important. As Jennifer had alluded to, and I want to just underscore, it's really important when the patient is a part of the conversation and has capacity, that it's still really important for the medical durable power of attorney to be a part, or the agent for that patient to be a part of the conversations and to document who we're having that conversation with. We did remove the box of the summary of the medical condition. That box is now gone. There are a couple of reasons for that. Number one, it was rarely filled out. Number two, it really didn't add anything to the decisions and the care that was being defined on the form. And I think number three, there was really some concerns that were raised around privacy issues that patients were bringing up about having their diagnosis on a document that may be hanging on the refrigerator or accessible, when it really didn't add to the definition or how we were providing care when we were following the direction on a most forms. So for all of those reasons, the box around diagnosis and conditions was taken away. That actually allowed us to do something that I think is really important, and that was to be able to move information that used to be on the back of the form, specifically around the medical durable power of attorney or the agent for that patient, to move that to the front of the form. In cases where photocopies were made, sometimes hurriedly, only the front page of the form got photocopied to send with the patient. Even though the original needed to be sent, it's often copies that get sent. And to not have that information available when that patient ended up in the emergency room was really made it difficult and a little bit more challenging for example, in the emergency room, for the emergency room staff to know who do we need to contact to help make decisions relative to the patient's care and decisions that we need to make right now because of the changes in condition. And then all of the same obligatory signatures for, as is the case with any medical orders, need to be signed by a physician, nurse practitioner, advanced practice nurse, or physician's assistant. So with that, and actually if we could just go, can you skip over the question slide, and I want to just point out a couple of things on the resources slide, and you will also have this information in your handouts, that a lot of information, a lot of things that we have discussed are gone into more detail at our website at the Colorado Advanced Directives Consortium, which is at the top. I also want to really underscore and highlight the palliative care best practices, which is available on the CIVIC website. And this is work that we had started actually about 6 years ago and then did a revision with CIVIC about a year and a half or 2 years ago now, really looking at more detail and more content and structure around best practices for palliative care, specifically in the long-term care setting and relative to hospice. There's a lot of good information that is in there in identifying patients who, at various timelines in their disease processes, that are appropriate to either initiate or review the conversation around specific orders relative to their end-of-life care. And then a couple of resources at the end, the Pulse website, a lot of great information from various states and what's happening nationally at www.pulse.org, and some resources from Caring Connections as well. We also on our website have available Your Right to Make Healthcare Decisions, which goes into a little bit more detail around advanced directives and the content of Living Will's 5 Wishes, Medical Durable Power of Attorney, the proxy process, and that's also downloadable from our website. So I think with that we have about 10 or 11 minutes left to take care of questions and to address any comments that you all have at this point in time.
Great. Thank you both for being here and sharing this information. We have one question that's already been submitted as the rest of you compose your questions and enter them in the chat box. We have a question from Amy Holk, who I know is still with us on the phone. As we use the MOST form in the home setting, how are the EMS and fire departments being trained in regards to accepting and following the MOST form?
I'll tackle that. The short answer is inconsistently. When the MOST was originally passed by the Colorado legislature, it was in a year where there was no funding available for picking up the trash, let alone anything else, and there was not a fund set aside for comprehensive training. The Colorado Department of Health did send out some very brief information to the EMT services around the state, and the Colorado Advanced Directives Consortium, along with the Colorado Center for Hospice and Palliative Care and Life Quality Institute and other organizations, have been doing a lot of education since then. So I would just say that there are some first responder services that are very up to speed on this and are very well familiar with it and place a lot of confidence in it. There are others who still are struggling and don't really quite understand it and don't understand the regulatory or legislative authority behind it. So my request and suggestion would be that for all of you working in facilities and from your setting to reach out to the first responders that come to your facility or work with your patients, or are, the home setting is a little bit more difficult for that, but to reach out and to extend education to the EMT services that you are familiar with. I'll also just mention that with the revisions to the form, we are going to be launching a sort of second wave of education around the most in order to familiarize people with the new form. Just to quickly point out that the new form you won't have to redo any forms, in order to update it to the new form. The old forms will still be valid, but it does give us an opportunity to do some additional education, and more information specifically around plans for that will be available from the Colorado Advanced Directives Consortium website when we have more information. So I hope that answers your question. We'll go from there.
All right. This is from Joyce Jennings. How is training with nursing homes being addressed? I have some of them telling me they keep the original when I am checking on my patients in their facility.
I'll say that and we know this from some informal surveys that we've done over the last couple of years, trying to get a feel for how knowledgeable the different sectors of our healthcare system are around the most, who's using it, how well they're using it. And I do have to give some kudos to the nursing facility sector for really adopting the most pretty thoroughly. I think we could say that probably in the neighborhood of 80% of our facilities in the state are at least familiar with the most, and many are using it regularly. The issue around the original of the form is one that we struggle with, and in all of our trainings with nursing facilities, we do emphasize that the original belongs to the resident and should be sent with them if they leave, and then we get a lot of pushback. So, copies and faxes and scans are just as valid as the original, and what I usually say in presentations is, this is not a hill I'm going to die on. If you absolutely have to keep the original in your chart, I'd rather you had it and you were using it and sending something with the resident. I don't much care at the end of the day whether it's an original or a copy, but technically the original should go with the resident, and for partly the reason that David pointed out, then we have both sides of the form. We have all of the information that we need, and you can keep a copy in your chart. But it's not an issue that I think needs to be a huge bone of contention.
I think this is also something that really needs to be looked at, and we refer a lot to, for example, the nursing home patient who ends up going to the emergency room and then ultimately coming back to the nursing home. But I think that this is a piece that in the subacute setting, in the rehab setting, that is really important to look at for those patients, and again, it's a limited number of those patients that a MOST form may be appropriate, but when one is completed and they are leaving the facility to go to an assisted living, or they're leaving the facility to go back home with home health, as just a couple of examples, that those are times that it really is important that the original goes with the patient. That is the recognizable form that will be on a refrigerator or on the back of the front door, kinds of examples. And those are the times that I think it's a little bit more imperative that we're attending to sending the original form with the patient.
Wonderful. We have about 6 minutes left. Does anybody else have any questions they'd like to submit?
Maybe we can repeat where the handouts will be available. Thanks.
We will be posting the recording of this webinar and the a PDF of the slides as well as all of the handouts on the HTC site under Webinar Archives, and they'll be up within the next few days.
Well, one of the handouts is a complete copy of the most current draft of the revised form, and I would just request that when you do get a chance to look at it, to think about it, review it with your colleagues, take it back to your facilities or your agencies and share it around. And if you have any further questions about it, you can certainly contact David or myself through the consortium website, or if you have particular feedback, we would love to hear that. It is not yet completely cast in stone. We have been working on it and massaging it for the better part of a year, but there is still opportunity, and fresh eyes are always welcome. So when you do get an opportunity to look at the handouts, if you would feed back to us any questions or suggestions you have, that would be very helpful.
It's one of the things that as we've worked over the last few months on these revisions, that a lot of the changes that were made were based directly on feedback that we had from all of you who are on the front lines and using the forum and having the conversations and utilizing the process. And that feedback is really something that is really, really valuable, and that's why I really appreciate the timing of this particular webinar to be able to put that out there, because the feedback that you all have after going through the presentation today is really, really valuable to us if there's any further adjustments that need to be made. So thank you in advance for doing that.
We did have a question come in. Peggy is wondering when the MOST form is going to be cast in stone.
Okay. We're expecting at this point that it'll probably, the launch of the revised form and the reboot of the education will probably begin in earnest after the first of the year. We are in the process now of circulating the form to various stakeholders, associations, and users for their feedback. In addition to this webinar, David and I gave a presentation at the Healthcare Association conference, was that last week, I guess? And we'll be presenting at the hospice conference coming up. So we are in the process of getting that feedback. So look for the launch after the first of the year. But in the meantime, and forever, probably the old form will still be valid and available.
Wonderful. And did anybody else have any other questions? All right. Again, the webinar and all of the slides and handouts will be posted on the Healthy Transitions Colorado website by the end of next week. Also, we want to give our thanks to Dr. Coates and Jennifer Ballantyne for sharing their expertise with us today. And thank you all for joining us as well. We hope it has been a valuable use of your time and that you gained information that you can use to further your care transition efforts. Have a good day and happy fall.
Thanks very much.
Thank you all.